So welcome everybody to Voices in Vascular Access. And so originally this was going to be a vascular access specialist, and he wasn't able to make it onto the plane. That's the quick version. So we decided who better to put this together than a group of people who have lived experience. So when Dr. Mercer arrives, we'll find him. He's the physician representative. I'm representing the caregivers. And we also have two patients whose one is more longer term and one is more newer term to this. And what I want to do is have this more as an open, we're going to ask some questions about, I'll have some questions for each of the panelists, and then we're also going to have time to ask questions. We can't give medical advice, right? But we can share lived experience and things that we've heard. We can share things in the guidelines and so forth like that. So to get started, I'm just going to have you introduce yourself and how long you've been on parenteral nutrition and a little bit about yourself.
Hi, I'm Reimer. I've been on TPN for 17 years. And I'm currently in school to be a social worker, and that's pretty much what I spend my time doing. So, here's the...
Hi, I'm Luccas Borges. I've been on TPN for 2.5 years, so much more recent to it. After a crazy skiing accident, I was super lucky to be alive. Have had 8 different lines, 3 due to infection, and a couple exchanges over the wire. From Brazil originally, have moved around a bit growing up, studied economics at Harvard, and live in Chicago, and am getting an MBA at the University of Chicago. And
awesome.
So, yeah.
Great, awesome. Glad to have you guys here. And then my specific experience is that Manny has been with us for TPN specifically, is almost 11 years, almost 12 years. There we go. So that's my experience, and we're just going to ask some questions of each other for a second here. But one of the first things is we call it a lot of different things. Has anybody noticed that? Some people call it parenteral nutrition or PN. Some people call it TPN for total. There's even one called PPN, and even the clinicians can't agree what that first P is. Some say it's partial. Some say that first P is for peripheral, and there's arguments. I've even asked the experts, and they got into a little fight over, no, it's this, no, it's that. So it all is the same stuff. These aren't different terms, but when I first got into this world, it was really confusing to me. And so just a really high level, too, about the different devices. So as you guys know, you got veins, right? And if you guys know this, then you can sleep for the next 30 seconds. If you don't know this, I didn't know some of these things. So the more central you have, so that's why they call that in the central area, and then the further it gets away is peripheral, right? That makes sense. And so, but blood and veins go in a circulatory system. We all learned this in 3rd grade science, right? And it was never relevant to us until we became on parenteral nutrition. And so if one starts here, in about 3 or so minutes, it's going to be back to here. If it starts here, in about 3 or so minutes, it's going to be back to here. And so it's a circulatory system. So no matter what goes into our veins, it matters. It's extremely important where it goes, right? And then there's the different devices, just really quick, high level of those. Even people who don't have central lines, maybe people in here who are caregivers or clinicians, you probably have had at least an IV in your life, right? They're more likely to be here or here. Don't get us started on that's not where they should be, but that's another whole story. I worked for the Vascular Access Association for years as a patient advocacy person, and I learned way too much about vascular access, right? And so those are the peripheral. The closer they get to the heart, the more it's central. But really what counts is where it terminates. And I don't think people explain that well. So there's a start, so that could be here, it could be here, it could be a midline maybe, it could be, a port, it could be there's all the different, tunnel catheter, all of the different things. They can start in lots of areas. Where the tip ends is what makes it peripheral or central. And not everybody, even physicians, clinicians, even understand that. And so that's extremely important. So that's why I like the tip location, if you've ever had to have that checked. So heart, and there's a little bit of controversy as to where that should end, upper 2/3 of the right atrium, or is it in the cavo-atrial junction, or is it what, I don't know. Like, they don't either. So there are some, it's still within a couple, like, very close. I mean, we're talking very, very close. So it's somewhere central. What happens is if it comes out of central, it's no longer right there. And why does that matter? Is because right here is the velocity, the pressure, right? So the veins go to the heart, right? Or yeah, and so veins go to the heart. I said that backwards. Yeah, so veins go to the heart, and then the arteries, did I say, the other way around, right? Yeah, away, yeah. So I got it. I'm like, so people are looking at me crazy, and I'm like, am I saying this backwards? I haven't slept in a minute. So there's the faster it goes, there's a lot of pressure right here, right? And so it needs to go fast. So some of these meds, especially parenteral nutrition, has high, what they'll call osmolarity or osmolality. There's all these like terms. What it means is it needs to go very quickly, otherwise it's caustic, right? It needs to kind of move pretty quickly. So it can cause a lot of damage in the various areas. Dr. Mercer, come on up. And so there's just a lot of things that matter as to where it's placed. And I'll just tell you, so like Manny was 5 when one of his lines was placed, very nicely central, and 5.5 years later, he had grown. You know, he went from 5 to 10, and it was no longer central because he grew, right? And so it started causing complications, but you can't know that right away. So there's the things that are long-term versus short-term, and then just a really quick recap is there is one of the vascular access specialists that I know from AVA, and he was in a speech one day, and he said the average central line is in for 6 days, and I audibly gasped because Manny's had been in for more than 5.5 years at that point. So we're talking the people that need these long-term, so like we consider her long-term, and in Oley terms, 2.5 years is new, right? In the medical world, that would be considered long-term vascular access, right? So one of the things that I think Oley needs to do a good job of is partnering even better with AVA. We're already partners with them. And say, you know, we need to talk about guidelines for long-term vascular access. And so one of the most heartbreaking conversations that I ever hear is people saying the words, I'm out of access. I'm almost out of access. That should not happen. That shouldn't happen, and yet it does. Now, if it does happen all the time, because we can't have a crystal ball going forward. How many are you gonna need? How long? And so one of the best things I could tell everybody here is every single line matters. And so we're gonna talk today about how it gets placed and who places it and how to take care of it, when to remove and not to remove. We can talk about all those different things, but long-term vascular access matters. So that's just a really, really high level of vascular access. And we can talk about any of these things when hopefully you're stirring some questions. So Dr. Mercer, we're just asking everybody to tell who you are and what you do in the world, because I'm caregiver, long-term, shorter term. What do you do in this ecosystem?
Medium-term clinician. No. So I'm a surgeon by training, but I spend most of my time not doing surgical stuff. I spend a lot of time doing medical management of patients with short bowel. And so I'm a transplant surgeon by training, but transplant's a really, really small part of my life. And probably 98% of my life is trying to avoid transplant. So I look after children and adults at the University of Nebraska. We have a pretty big program, probably the largest in the world, that looks after everyone from sort of newborns to end of life. And I'm in the trenches all the time. So I just do it every day, 5 days a week, weekends once in a while. And so I've learned a bit of stuff over the years about, putting in lines and dealing with complications and stuff. So I'll help however, whatever questions you want or whatever I can do to help.
Well, thanks for having me. Thanks for being here. And we'll keep that for a second, because one other thing is he's on the board of trustees, right? And I haven't seen them yet, but what socks are you wearing today?
Oh, you know what?
What?
I have cool shoes.
Cool
but no
shoes,
socks.
yeah. This man's either wearing the coolest shoes or coolest socks ever. I think you have the biggest collection of socks I've
I do have a
ever
lot of socks.
heard of, yeah.
Like Imelda Marcos numbers of socks. Yeah, it's crazy.
So the first question that I want to ask, just in general for you guys, is When those first lines were placed, how equipped did you feel with that very first line? And what kind of training were you given when you went home?
Well, I was 13, and so I was at a children's hospital, and for some reason they let me pick what kind of line I wanted when they gave me really, really false information. First of all, they told me if I got a port, I could de-access it every single day, and then it would be like I didn't have a line, and how fabulous would that be? Well, it wasn't true. So, but I got the port before I learned that information. And really, the only training was like before I was able to be discharged from the hospital from that stay, was that one of my parents had to like be checked off to be able to access my port. And so my 6'2" large father did it, and they were like, use force, and it was not a great moment for anyone. And really, for my line care, I wasn't taught anything. It was all just, you're gonna go home and you're gonna have a home health nurse. So,
OTJ.
yeah.
What about you, Lucas?
There you go.
Yeah, so I was living in Chicago at the time. I was 22 and was had the skiing accident in Salt Lake City at a center that was fantastic and quite literally saved my life from a trauma perspective, but did not have an intestinal failure program. And so they too gave me a port, which was also not a great solution at the time. And so, but was able to go home. It was constantly accessed, and a home health nurse would come change it once a week. And very quickly, it ended up getting infected. That was the last port I've had. But as far as training goes, that too was, just at home health nurse will take care of it. And it's been a slow transition, but I'll do everything myself now.
Well, and I would ask too is sometimes the port is the right answer for some patients, and sometimes it's not, and sometimes a PICC is the right answer, and sometimes it's not, and sometimes it's a tunnel catheter, and sometimes it's not. And I think this needs to be a conversation among your team. And the thing that I would like to emphasize is that we are also part of that team. And I could tell you when Manny, for example, he's a wheelchair user, and the first time he got a wheelchair, they said, what whistles and bells do you want? I'm like, I have no idea. I don't have that lived experience. But after that first one, I started making a list because eventually he would need a new one, and I had ideas by the next one. Same thing with our vascular access. The first one, I had no clue. By the next one, we had some ideas. Like one was the tunnel was so close to his shoulder for 5.5 years. I basically cursed the surgeon's name every week because I couldn't keep a dressing on it for 5.5 years. 1/2 inch to the west would have changed his life. Or thinking about bra straps, or thinking about if your 12-year-old daughter is eventually going to hit puberty and now we can't access her because it's too deep if you have a port. So just some lifestyle things. If you're thinking ICU patient and it's going to be removed before you leave the hospital, then you're fine, right? But if you're going to go live like my kid does at Disney World with a backpack, then we need some consideration. So I'd ask you, Dr. Mercer, what should be the beginning conversations the first time somebody has a line?
For the very first line you've ever had. Well, there's a lot, because there's a lot of conversation that leads up to why that happens in the first place. So if it was something that happened when you were a baby, you sort of have it, and it's really part of your life right from birth. But let's think maybe of a scenario where it's coming later in life. There's a lot of different issues, and there's a lot of different philosophies about what to do. I'll just touch on the whole port line thing first of all. So ports have a role, but a port is a good long-term access to be accessed intermittently, right? So if you said, gee, I need long-term access, my veins are crappy, but I need fluids 1 day a week, or something like that, or I need, they're originally designed mostly for cancer patients, right? So for chemotherapy, 1 week out of 1 4-week cycle. But if you have to be accessed for TPN and you're accessed daily, the problem is you fundamentally breach the defenses of what that port does for you, right? The port is good because it's under the skin and you can take the little needle out and you don't have to worry about it. But that needle goes through the defenses of the port. And now you have an open pathway for bacteria can come down that needle because there's no block to that. And so I'm not a big fan of those for daily access because I really think you've obviated the point of the line in the first place. You're sort of opening yourself up to the bacteria and saying, okay, well, hopefully you don't crawl down that little metal cannula. So some people like them. I'm just not a big fan. And the other thing is there's a finite limit to how many times you can poke through the skin over top of a port. You know how the skin gets kind of all thinned and you get those multiple little holes and stuff. So they kind of have to be rotated around, whereas you don't have to do that. You can have a Broviac for 5 years or 6 years or 10 years or whatever. Things that you want to have in those first conversations are, so we can put these lines pretty much wherever you want them to be. And so when I'm doing them, and let's just say it is a scenario of a 13-year-old girl or something, then what I actually do is have them come and bring a bunch of different outfits and say, what kind of necklines do you like to wear? If they're wearing, obviously it's a little different if you're 13 and maybe you're wearing a training bra and it has the wider straps and stuff like that. You have to think a little bit about that. But I'll have them bring in different kinds of necklines and decide what sorts of things that they like to do, because we can bring the lines out wherever you want to. And so some kids like their lines brought out, down under their arm down here, so they can wear V-necks and plunged fronts and all kinds of different kinds of fashionable stuff. But if people mostly are wearing crew necks and higher collars, then it's not such a big deal. You have to be a little careful when you're placing them on girls because you don't want to be anywhere close to where they'll have developing breast tissue because you don't want to distort their breast as it starts to develop. So there's just lots of different thoughts about the way things can be, and I think people don't necessarily know that. So you just show up and they go, oh, we're going to get you a line, and you go, oh, okay, and it just comes out wherever it comes out, and that's just how it is. And if it's right where your bra strap is, or if it's for a little boy, it's right at the, they're running around all the time, right? And if it's right at the crease of their armpit where you can't get the dressing to stick on all the time, that's a huge pain in the ass, because nobody wants to do 3 dressing changes a day. And you want your kid to be able to play outside in the yard, and so if they're playing out in the dirt and their line, the dressing comes off twice a day, well, that's a huge annoyance. So, amazing. So the problem is, if it's your first line, how do you know what to advocate for in the first place? Because no one's ever told you. So it's a little bit of a, I almost don't know what the answer is, other than having like a whole bunch of really educated clinicians who would bring those issues up in the first place. In many cases, hospitals may have a line team. And so they might, even though they're not necessarily the ones putting it in, they might be somebody who you could talk to who could give you some advice, kind of like how ostomy nurses can help you to choose the best spot based on the belt line of your clothes and what you like to wear and stuff like that. So, absolutely. So it's a hard thing. I wish I could tell you here's what to advocate for, but you all are here, so you would know to do that. But somebody who's brand new wouldn't know that. So it's kind of a tough one.
I agree. So except if you're a Dr. Mercer patient, don't raise your hand. Anybody else ever have that conversation ever with any of your clinicians? Raise your hand. There's like, okay, how about your first line? Did anybody have that conversation, right? And it's extremely rare. And so good for you that you, what's that? Well, that's the thing. And so what I would say is if the world existed of people like Dr. Mercer, we'd be good, right? Maybe not perfect, right? But we will work together. But he's aware. He's aware. And so not everyone is. And so that's why it's so important for us as Oley that we start to help you advocate. And advocate doesn't mean go in there like a screaming bear, right? It's to be heard. We want to be heard and we want to be part of the conversation. As Maisie said earlier, we need to be invited to the table. And that's extremely important. So I'm going to ask one more question of everybody, and then we're going to open up the floor to you guys about whatever questions that you guys have. So for us, and what I just heard you guys say a little bit, is almost all of our really big complications came very soon after having vascular access for us. So Manny had probably, I think it was 8 lines in 3 months. One was infected, his one and only line infections in 12 years, right? Some breaks that were at the nurse's hand, and some other things like that. Almost everything for our complications came very early on, and then we had a stretch of 5.5. Now we're at 4.5. Like we had a little bit of time in between. Lucas, I heard you say that early on you had a whole bunch of lines, and then early on? Are we learning as time goes? What do you think the effect of time is on vascular access?
Yeah, no, I think that's a great question. I think the one thing that comes to mind is that it's important to remember what it was like to not know.
Yes.
You know, I think at the very beginning, and now looking back, it's easy to say, oh, well, you have to consider the lines, and oh, well, you know, it's important to think about them in the long term. Well, what does long term really mean? And you know, I think at the very beginning, there are so many things, and often, you know, I think it's easy to think of the line as, you know, the least of your problems.
Yep.
You know, there are so many changes, so many lifestyle, you know, so many things that are easy to think of as more critically important, and that may be true, but I think it's the line falls under one of those categories of things that, you know, for a number of reasons that we all know, can be very, you know, influential on quality of life. And so I think for both for patients and for clinicians, it's important to really think about what long-term really means.
Right.
Not just, you know, on a 1-year horizon, but, you know, 10, 20, 30 plus year horizon. And I think that having that perspective and having the perspective of how much the line, you know, what kind of line, where you place the line, ends up, you know, sure, maybe it's not the most pressing thing on day one, but, you know, by week 2, you're, you know, dealing with the line and changing dressings and, you know, all sorts of things that start to influence quality of life. And so from the beginning and making that transition from, you know, nursing and having a home health nurse come visit versus being able to be autonomous or independent with dressing changes and things like that, having such a big impact on quality of life. You know, I think in my case, had the port at first that got infected very quickly, had a Hickman catheter that eventually got infected because of my skin didn't like the silicone, and so kept getting granulation tissue that was hard to manage even after, you know, a number of potential solutions, you know, silver nitrate, all sorts of things. We tried it. But since then, you know, the frequency of line infections have, you know, decreased drastically. Haven't had one in a while. Well, I say that, but had one a couple weeks ago. Treated through it. It's okay now. But have had, you know, a number of exchanges over the wire, and have gotten to the point where, you know, I had an exchange over the wire and was in class less than 30 minutes later. That to me would have been, you know, unthinkable 2 years ago.
Exactly.
So yeah, I think having that perspective from the beginning, and, you know, really thinking through what long-term really means. And I think from a clinician standpoint, understanding that there are a number of different changes happening for the patients that they're trying to process and digest all at the same time. You know, having that mindset of maybe we can make these little adjustments on the margin that really have profound impacts, I think is critically important.
Perfect. How about you, Lauren, the effects of time?
Effects of time. So I do want to note, this is a wild thing, but my first port that I just told you about lasted for 5 years.
Wow.
So it sucked because they, as you were talking about placement, they were like, oh, she's going to need a bra soon, so we're going to put it right here, right where her bra's going to go. So it was awful the whole time. But I learned that, so I didn't want to port after that happened. But time-wise, I have entered into the world of tunneled lines, and it is honestly, no one knew, like everyone I was around didn't know enough about them to educate me or themselves on how to place them. So unfortunately, these past like 5 years, and I apologize if I get emotional, but so sorry. They were placing them incorrectly, and I had to go do the research and find an article that said the Dacron cuff is supposed to not be at the surface level of the skin.
I was just waiting for my turn to talk.
Yeah.
Yeah.
And so I fortunately had a really great interventional radiologist who read the article, and he was like, okay, I will do it. He did not love the idea still. But since he placed that line, it's been going great. So let's just hope it keeps going great. And so I think time, I don't know. I feel like I'm still learning things.
Yes. That's good.
All the time, even though like a tunneled line is old news, you know. So, and then I was gonna comment on we need to think long term. I loved what you were talking about on that. I think clinicians in general, unless you're at a specialized clinic with Dr. Mercer or the several around the country.
The few that exist.
Right. I don't think anyone is thinking of TPN long term still. The amount of times that I go to a general doctor and they're like, "What? You've been what?
It can leave the hospital.
Can the students come in?" And I'm
I know.
So
Exactly.
I while I completely agree, I think we are a ways away from that, and but I really hope that conversations of patients like us in those clinics can help people break their bubble a little bit, and hopefully we can start thinking of those things because most times people, you tell them you go to the ER, they're like, well, why do you have the line, and how long has it been there? And you're like, anything over 6 days, they're like, we got to get that out of here.
Exactly.
So,
High risk. Yeah.
So yeah.
Yeah. for sure.
So anyway, time and yeah.
Go for it. Tell whatever you want to say. I won't even ask you a question. How's
Well,
that?
yeah, so just some things that are probably important for people to know, because obviously you're the protector of your line, you know, you're the advocate for your line, you're the defender of your access. So I think you can tell them. One of the things that's happened more lately is they tend to do lines in IR. And so if you go down to IR to get your line, you sort of get the IR person of the day. And it's often going to just be a fellow or a resident. And they're going to be very, very good at getting lines. There's nothing wrong with them technically doing it. But they're not going to give a bunch of thought to what things look like for you in 7 days or 2 months or 4 months or something like that. So things that I think you can bring up that are very, very reasonable. I think you can choose your exit spot. And if they say, gee, you know, your access is tough, because maybe some of you do have more challenging access, that's fine. Take a little marking pen and mark 4 different places and say, you know, mark number 1, number 2, number 3, and number 4, right? This is my preference. The reality is you can put a line in a vessel here and tunnel it out over here. Like you can tunnel lines anywhere you want to. They're sometimes kind of sore tunneling across the midline because that tissue gets kind of stuck right on your sternum there, but you can technically do it. Little boys and little girls that pull their lines out all the time, I can bring them out between your shoulder blades. So that they're just not even on the front. So that, you know, it's kind of a pain in the OR, but you can do it.
Yep.
So then they can't pull their lines out. So if you have an active little 2-year-old or 3-year-old and they're wrestling with their siblings and stuff, you know, you can do that. So you can definitely advocate for where you want your line to come out. Second thing, that Dacron cuff thing is super important, because what most people who are relative rookies at doing this is they put the line in, and the way it works, you know, we put this little tunnel thing in, we have a wire, and we're watching on an x-ray, and then you sort of pull the line up through the skin, and then that cuff, as soon as it gets just inside the skin, there's a teeny bit of resistance, and then the average person will just say, okay, good, and they cut the line to length, put it down the little, you know, into final position, and you're done. The problem is if that Dacron is close to the exit, then it gets chronically infected, and it'll never heal. You'll get that granulation tissue, and it doesn't matter what you do. You can put triamcinolone, you can silver nitrate it, you can do dry dressings, you can do anything. It will never, never, never get better, because the body doesn't want that to get better. It's got a foreign body right at the epithelium there, so it's never going to heal. So that little cuff has to be pulled inside. It doesn't have to be pulled in a ton. I usually try to pull it at least a couple of centimeters, but that needs to get pulled in a little bit further. So that's just, and that's, you know, doctors are egotistical, right? But who cares? Like, just it doesn't matter. You tell them, I need you to pull that cuff inside. I've been doing this for a long, long time. And they'll say, oh, I've done a lot of lines. Don't you worry. I do this all the time. I know exactly what I'm doing. And you say,
Do
that's
we have
great.
you on speed dial to?
But I know this is how the conversation goes for you. It's like, oh, well, you don't have to tell me what to do. And they're gray haired. They've done it forever. And you say, I'm sure you're really, really good. Can you please just make sure you pull the cuff in 2 centimeters, right? All that has to happen. You can be all kind of humble about it, and you'll at least get what you want, which is the most important thing.
You can bring up an article. I can send it.
Yeah, sure. But usually people are going to be kind of cool about that, because it isn't that hard to do. It's sometimes hard with really, really tiny lines for little babies, like the little 2.7 French and 1.9 Frenches, but the 6.6s and stuff are easier. and then 9 French ones.
Yep.
What else? Getting lines pulled. So generally try to not get your line pulled, right? You know, everyone wants to pull your line all the time. Anyone who
Yep.
doesn't know anything is like, oh, we got to get your line out. Don't pull your line out unless you really, really, really,
Yep.
really, really, really need to, because it's just easier not to. Those cuffs are designed to stay in, so the cuffs don't have to come out. So people will say, oh, we got to take your line out. We're going to take you to the operating room. We're going to put you to sleep. We're going to make an incision. We're going to dig in and root your cuff out and pull all that stuff out. But they're not designed that way. They're designed so that the adhesive between the cuff and the line has less stickiness than the Dacron does to the tissue. So all you have to do is, I mean, we just do these in a clinic, right? It takes 2 seconds. Like you just pull on the line, just a gentle, firm pull, and the line will give and it'll slide out of the Dacron cuff. And the cuff just stays behind and the line comes out. So it takes 2 seconds. You don't have to have a big procedure for it. And so you have a little teeny lump there. But, you know, so if you're a skinny little kid, you can sort of feel the lump. But for most people, there's enough tissue that you don't really feel the cuff one way or the other. And so you can have a bunch of cuffs in there and it doesn't really change anything. Sometimes if people don't like them cosmetically and I have them asleep for another reason, I'll, you know, pop out the cuffs just because it's easy to do. But thank you. What else? I don't know.
So first of all, thank you guys. I don't know if you guys are learning anything or have more questions or go like, well, I wish I had a phone a friend sometimes. That would be, in fact, I've asked my hospitalist one time, can I have the secret handshake? The one that you guys talk to each other so you know that I actually kind of know what I'm talking about. But I did this stuff not all that long ago, and I'm very kind. I know my people. I walk in. The surgeon that we had used for years is moved states away, so he can't do this anymore. And so this new surgeon comes in, and I did my checklist, and we went through it, and she was great, sounds wonderful. A 4.2 is going to be placed again, blah, blah, blah. So imagine my horror when a 9.6 comes out, and he doesn't need one. He doesn't need one that line. He did not need that, and I'm sitting there like, now it's done. And he had a lot of complications from that. So I go backwards, and I'm horrified. Like, what did I do wrong? How did I not advocate enough? I thought I asked all the right questions. I thought I had the right conversations. I thought I did this. The truth is what happened is because I got surgical notes and so forth and found out that she had tried to place it on another side. She had 2 sizes in there, and she placed it on one side. It failed. She couldn't do it, so she went back in the other one with the other size. And so rather than going and getting more stock of the right size, I'll just throw this one in. And
there is a teeny bit of a national shortage right now of the 6.6s.
Yeah, that's not what that was, though.
But there actually is for what it's worth.
Yes, but yes, there is. And that's another complication that we can't do anything about. And so I guess my point is this, is I felt like a failure, right? And I want to be able to voice that too. What did I do wrong? Absolutely nothing. And so if sometimes the perfect doesn't happen, we have to live with some of those things too. So we can do the best we can, but at some point, we also have to realize that, you know, I wasn't a failure as a human being and a mother. I didn't do anything wrong. Some things happen sometimes. So I do want to give the chance to some questions. So if somebody can, I'm going to walk out in the audience, and we will hand the mic around, and what questions you guys have. So I have one started back here. We'll get to as many as we can, so we'll try to keep our answers as short as we can, just so that we can answer as many as we can.
And let me give you one other quick tip, just while I'm thinking of it.
Go for it.
And then we'll give you a question. Is when you get a line put in, also talk to your team about getting a repair kit. So get them to order you one through your home care so that you have one at home, because if you have to go to generic emergency department, they're not going to have a repair kit. They're not going to know what it is. And it isn't rocket science, so they can actually even YouTube it, and they could figure out how to do it, although you'd be tempted to do that yourself. You know,
Yes, we would, yes.
And honestly, wink, wink, that's probably okay.
Yeah. Well,
But
and
you
just so
didn't
you
hear it
know
from
that
me.
insurance in different places do not allow that. And if they do, it's worth trying for. There's no reason not to. So I can't tell me lines have been pulled because they didn't have, we don't have that in stock. And so out comes a line for no reason. So it's a good idea to ask and push and be consistent about that. But if there are some exceptions as to why that can't happen. So you had a question?
Do the external stay sutures have to stay around the line? My daughters granulation tissue grew over them, her breast tissue grew over them. She had to be put to sleep twice to have them removed.
Usually when
we were told by the surgeon that they had to stay in, that they were holding the line in. I kept asking for them to be removed. It just became a nightmare.
They only have to stay in at the very beginning because the cuff hasn't grown in yet. So
About
it
how
really,
long?
Oh, I mean,
I've heard about 6 weeks, give or take.
a safe answer is 6 weeks. The reality is it's probably 3.
Okay.
But so usually I'll just take them out in clinic somewhere around 3 or 4 weeks because by then the cuff has grown in, okay? But for that first week, it really does, it can just slide out. So that's where if people are, the uninitiated is doing a dressing change, they can pull the whole line out by accident. So the stay stitch does help for the first couple of weeks. And then once the Dacron cuff is sticky enough, then the stitches can come out.
And because I worked for a vascular access organization, I happen to know the thingamabobs to doohickeys and so forth that exist. There are some other options for external stabilization. There's all sorts of different things. I see Tanya, who's the COO of AVA, is going, her jaw's on the ground right now. So there are lots of questions. Who's next for the question? I didn't see who was next on this. Alrighty, I'm gonna run up here real quick.
If you could talk a little bit about placement. My daughter had, like, from August of 22 to 21 to last year, had about 8 infections, and the line kept getting pulled and new. So our thought has been, how many places of access is there, and are there places that we should advocate for that we wouldn't think about?
Great
So-
question.
That's a good question. The generic access sites are 2 jugular veins, 2 subclavian veins, and 2 femoral veins. So we talk about the 6 sort of common sites. Those are ones that are relatively easy for anyone to get into. You tend to use the femorals last, just because then you have that little incision down by your groin, which is maybe not as clean as the ones that are up here. So we try to use these. There's not any special order that they have to be used in or anything else. Once those are all gone, then there's other things that you can do, but you start to get into more esoteric lines like transhepatics, where we put a little needle through your liver into your vena cava, and there's direct sticks into collaterals off the cava. So there's almost always a way to get some access. Rarely will you ever get to the point where you can't get any access. But yeah, those are so if you think about the 6 main sites, exit sites can be anywhere, and there's innumerable exit sites. There's a million of them. They can be wherever, so as long as the vessels are open, your daughter could have exit sites wherever she wanted.
Thank you.
I feel like we're at church out here all going like,
Preach.
I was just going to say, one of the biggest things that are difficult when I ended up in the hospital are protocols. Because, a hospital will say like, this is what we do. And it's unacceptable. Anything else is unacceptable. IR has protocols. Infectious disease has protocols. Different floors have protocols. My doctor's like, yeah, of course you can have that Broviac. You go downstairs and IR is like, we won't do that unless you have a PICC line as well. Yeah. And sometimes you have ridiculous conversations and you end up in situations where scare tactics are used of like, well, you're just gonna live here if you don't do what I say. Yeah. And as ridiculous as that sounds, like there are some times where it feels like, wow, it's my 2nd week here, and yeah, it feels like I might live here if I don't do what you say. And you were saying like that 6 days is that's the average, and that's insane to me. Yep. That's crazy that's the average. And I think, but when you meet doctors, that is the average. That's what you're meeting. You're meeting nurses that are like, oh, this is what an IV should look like, with stitches, with healing bandages. This is what it should look like. It shouldn't look like it's at home. It's been healed for 3 years, So I guess sometimes I feel like protocols are a wall. It's basically like, this is the protocol, end of conversation. And it can feel like, well, okay, now what? And I guess from a physician perspective or from the patients who have dealt with that, like, is the option leave to a different hospital? Is there a way to have a conversation? Is there a way to contact other teams that are okay with this and can connect with your team and be like, hey man, look, we're out here, please.
Help us.
Yeah.
We are here.
Yes,
We are
exactly.
here. What do we do? Because protocols exist for a reason, right? They're there for standardization, and I think we would all highly agree those are important things to have. What I advocate for is we need to have long-term protocols, and those don't seem to be as clear cut as the short stuff.
Yeah, this might not be the answer people want to hear, but you also have to recognize that you have rights as a patient, and you can say no to things. I know this is a really simple thing that happened while inpatient, where they wanted to do my dressing change, and I did not want them to do my dressing change. So then they let me do my dressing change, but then they were mad that I didn't put the, I don't use the bio patch, but I use a patch thing. They wanted me to put it around my line, and I was like, I'm not gonna do that. And this is through my bouts of thinking I had line infections, but it was really granulation tissue. So anyway, she popped off and said, well, I'm not the one here with a line infection.
Oh,
I was like,
really? Oh.
yeah. And I mean, really, I just said, this is, I don't know. You just.
So what I would say is this, our time is almost up, and I know there's tons of questions, right? And so here's what I would do is we're gonna have in the exhibit hall, we're not ready to go there yet, right? We have another session here, and then we're gonna go to lunch in exhibit hall. I'm gonna have a panel in there, a table that's gonna be an Ask the Expert. I'm hoping that Dr. Mercer will join at some point, so you guys can sit there as well and continue to ask questions. And then if we see each other in the hallway and things like that, because I think this conversation needs to go forward. And then one of the things that we're doing, in fact, right here in the front row, is my summer intern. We wave at everybody. This is Shaylee. And hi, Shaylee. So Shaylee's been on parenteral nutrition for a minute or two also. I'll leave it at that way. And we're working towards doing the background protocol stuff that says, what do we do to create a patient bill of rights? We're working to have conversations about how do we do long-term. Let's partner with Association of Parenteral and Enteral Nutrition, ASPEN, and AVA, and NHIA, and all those different things, because we need to have those conversations. Because people say, know your rights, and I'm telling you, nobody knows what our rights are when it comes to long-term access, in my opinion, because you ask different people and it's very, very different. There's some basic human right things, but for the most part, we don't have those. And so we want your voice. We want to hear, what are the pain points? If you haven't taken our survey, I'd love to hear that. We asked what's stressful, and I can tell you, I'll tell you more on Friday about it in the advocacy session. But what we're looking at is the number one pain point so far is complications related to devices. I'm not shocked. Are you? Anybody shocked? And so we need to have this conversation. So this is the beginning of this conversation, not the end of this conversation. So thank you to our panel today. Unfortunately, we got to run. We're going to our next session here, but thank you so much for being here today. I appreciate it. And we'll continue to have this conversation. Please come forward at various times. Thank you so much.